you. We can't say how how very thankful to you we all are.
Well, I'm pleased to be. Because as I said, I've always heard about Bangalore for 40 years. The research from Bangalore, and I actually visited Bangalore.
Or was that 40 years ago?
Well, of course, it was known for its research from, I guess, the 1980s. Yeah, is that 40 years? Yeah, that's 40 years.
That's right. Yeah. Oh, that's really great. And it's a matter of great fortune to have you here with us. All our students are waiting, and more would be joining. We have a number of our alumni as well, and everybody's pretty much excited to see you, first of all. And
I was in UK for a number of years, and I was fortunate to be trained by Professor Sir David Goldberg when he was in Manchester.
Yes, and so, of course, yes.
Yeah, and before that I was at Guy's Hospital. Somehow could never make it to Denmark Hill.
But of course, now that Guy's and the Maudsley are all part of the same.
But in those days, Guy's was separate, Maudsley was separate.
And of course, the head of King's College is an Indian person.
Yeah, Sujit Kapoor.
Yes, so it's amazing, actually. I remember him as a young researcher, a very brilliant researcher. But
can I ask you a personal question, Sir Robin? You mentioned 5 psychiatrists being fellow of the Royal College. I can only account
Royal Society, FRS.
Who is the 5th one?
FRS.
Freud.
FRS.
Freud.
Right.
Yes.
Okay.
Sigmund
Freud was a foreign member.
Yes.
And Professor Michael Rutter was one.
Yes.
Professor Sir Martin Roth is another.
Yes.
And you are in that distinguished line.
Yep.
Sir Martin was the president when I was inducted in college.
Oh, yes, yes.
Way back in 74.
The first president, yeah.
Yeah. Good.
Is that the background? Is that of the King's College, Professor Murray?
This is the Maudsley Hospital.
Maudsley Hospital.
Oh, I've never been there. The
you
Mecca.
Can never forget that.
Yeah, the Mecca.
Yeah. So King's College is just in front of that, if I'm not very much mistaken, Sir Robin.
King's College Hospital is in front of that, yes. And,
just in front of that. And yes. Institute of Psychiatry is behind this building.
Yes, there's a lot of building going on.
Yeah. And the child psychiatry unit is somewhere outside there.
Yes, they're in the middle of building a new one.
Yeah, and the de-addiction unit is towards the left of this building on the main road.
Sorry,
at one time, de-addiction.
The addiction psychiatry.
It's still on.
It is still there.
Yes, yep.
Ah,
good.
It's just. We're just waiting for another few minutes.
Shall I try my slides? Would that be a good thing to do while
please.
we wait?
Yes, please.
Oops, just as well I tried because I don't see them.
You can start screen sharing and then.
Yes, no, I haven't found them yet. Yeah. Any luck? Any slides?
We can see the slides.
You have to move to the slideshow mode, please. Yeah, that's right.
Okay, good.
Absolutely fine. Absolutely fine. That's great.
I gave a talk in China.
Oh.
And I thought it was just to one university department, but it turned out they had 5,000 psychiatrists watching, and we couldn't get the slides to work. It was terrible.
Yeah. Right. Maybe are they moving? Can you please just move one slide to see the slide? Yeah,
Yep.
that's fine. Absolutely fine. Yeah, that's great. Maybe we could you could now probably stop sharing so that now we have it on board so that we can start the meeting, and after we are done with the initial introduction phase, then we can start the slide sharing, if that's okay.
Okay.
Swapnajit, are we more or less ready? So
yes, sir. Yes, sir.
Okay. Probably just another couple of minutes. I mean, it's amazing to see, Professor Murray, that by the time I was trying to look up your some of the works, because I was familiar with your 1982, the Reveille, I don't know how you call it, Reveille.
Yep.
That's right. The discordant monozygotic twin study. That was kind of a path breaker or a trailblazer at that time. And then I recall when I was a student, and Dr. Kulhara is actually my teacher, and he has done a lot of work in schizophrenia clinical aspects as well. So we used to have some book series called Advances in Psychiatry or something like that. And there you were quoted as saying that if you keep all the facts of schizophrenia in a bottle and then shake it up, and then I think 3 facts stand out, something like that. It's familial or genetic, and the other is that, but from there it started the neurodevelopmental course. And it was amazing to see that in 2021 the whole lot of studies of this EU GEI, I'm sure you'd be probably talking about that, this whole series of studies, and they're just coming out one after the another, and still so very going strong. It's just amazing.
Well, I'm not actually going to talk about that, but I'd be happy.
Okay.
Happy to do it in questions.
Yes, sure. I think with your kind permission, sir, then we can. I think we may start now. Swapnajit, are we ready from your side? Yeah. Okay. Yes. So okay. Good evening here and good afternoon in the UK. I'm very pleased to welcome Professor Sir Robin Murray for giving the 3rd lecture in this distinguished speaker series run by which has been started recently by the Department of Psychiatry, Postgraduate Institute of Medical Education and Research, Chandigarh, India. The 2 previous ones, these are 3rd one, and the 2 previous ones were given by Professor Norman Sartorius, the first one, the inaugural lecture, and the second one by Professor Afzal Javed, the current president of the World Psychiatric Association. So today we have the 3rd one. Just to give a very brief background for those who haven't heard it before, and for Professor Murray as well. The Department of Psychiatry at PGIMER Chandigarh was started by Professor Naren Vig, NN Vig, in September 1963, after his return from the Maudsley, where he actually trained for a few years, and after coming back to India. At that time, psychiatry was heavily stigmatized, and it was mostly practiced in the confines of mental hospitals, and mental health was considered pretty much a low priority. Dr. Vig helped to establish psychiatry as part of a general hospital psychiatry in the community, and was a pioneer in Indian psychiatry. He also emphasized psychiatric teaching and research a lot. This tradition of excellence in teaching, research, and service continues till date. So as a new initiative to further enrich the academics of the department, and primarily to stimulate and motivate our students to see that the heritage of and the legacy of psychiatry, the department has started this distinguished speaker series, and the speakers consist of eminent psychiatrists and mental health professionals from all over the world. And they would share their experience, viewpoints, knowledge, but most importantly, I would say wisdom with the students and alumni of the department. And we hope that this will benefit and motivate and inspire our students tremendously. And today we are very fortunate indeed to have a person of the stature of Professor Sir Robin Murray, the doyen of schizophrenia research over decades, to deliver today's talk on a subject most apt and thought-provoking: schizophrenia, better understanding, better treatment. And I don't think that there are very many psychiatrists who are here who can talk, who are more qualified really to talk on this particular subject than Professor Murray. Just before I request Professor P. Kulhara, who is Dr. Kulhara is a chair, will be chairing this session. I would just like to share, with the kind permission of Professor Murray, the first email which I sent to him on 30th of August, where I wrote a long and a rather kind of, I wouldn't say exactly thought disordered, but definitely a very circumstantial email seeking his kind permission to give a talk. And I was almost, kind of gave it up and just said, okay, let me have a try. Nobody's going to kill me for writing a mail to Sir Robin. And lo and behold, that same day, evening here, afternoon there, and there I talked about a paper which I read when I was in Scotland for a year, which was called Mistakes I Have Made in My Research Career, published in Schizophrenia Bulletin in 2017. That was so fascinating. And so I just kind of took reference to that. And then I got the email, a small liner in response to my circumstantial and voluble email. There was a 3-liner email response from Professor Murray. Dear Debashish, I should be delighted to contribute to this worthwhile series. Thanks also for reading my mistakes paper. Of course, and then he writes, of course, these are the only the mistakes that I recognize, probably many more. Let me think a bit about the topic. Robin, that's how it started, and here we are. So with this brief welcoming note, Sir Robin, may I request our chairperson, Professor Param Kulhara, to kindly welcome and introduce briefly the speaker. I mean, he hardly needs any introduction, but still some introduction, and then we can go to the speaker. Swapnaji, next slide.
Thank you very much, Debashish. Good evening, good afternoon, Professor Sir Robin. It's indeed, I won't say pleasure, it's really a privilege that I'm introducing Sir Robin. He needs no introduction, therefore I'll keep it simple, and I only highlight 4 or 5 things about his career, about his life. He's Scottish by birth and was trained in medicine at Glasgow. And then around 1972, he moved to IOP, Institute of Psychiatry, and King's College, where he remained till he retired or gave up active service, or whatever term you want to use. And during these years, he has been a voluminous researcher and has published, as he has said, 800 papers, not all of them boring. In fact, they all are very illuminating. He has been chairing the psychosis research group, etc., etc. He has won almost every award in psychiatry, both at UK, international level, Norway, Sweden, Finland, you name it. No country has been left behind in honoring him. So that is his academic legacy. He is still very active in academic and research psychiatry. Second, his greatest achievement is to become a fellow of the Royal Society. Not very many people become fellows of Royal Society, let alone psychiatrists. And as enlightened by him, there are only 5 psychiatrists who have succeeded in becoming FRS. So that's the greatest achievement a scientist can get. That is recognition at home by a society, none other than the Royal Society. Third, his greatest achievement is knighthood, to be recognized by the sovereign of the country where you are for services rendered to medicine. And that's how he is now Sir Robin. Fourth, I think his greatest achievement is, which not very many people know, And I'm sure not very many people are familiar with the concept, but his greatest achievement is to get a fresh shift on his departure from Institute of Psychiatry. And for those who are not initiated into this term, it's a German term, meaning collection of papers and research articles, etc., about a fellow researcher, teacher, or a mentor on a special occasion. And rightly, the fresh shift is called Schizophrenia, the Frontier, Final Frontier, and has been edited by Anthony David, a very well known in psychiatry, Shujit Kapoor, who is the Dean of the Institute of Psychiatry, and Peter McGuffin, who is the Master of Genetics. And it has contributions from almost everybody known in the field of schizophrenia, mostly Sir Robin's students or PhD students or alumni or colleagues or whatever. So with this brief introduction, I pass back to Debashish and Sir Robin.
Well, I think now it's time to pass the microphone and the video to Professor Murray himself, and we are all eagerly waiting for you, sir, to start your talk. Professor Murray, please, if you can start sharing this screen. Yep.
Can you see it?
Yep.
Okay, so thank you very much, both of you, Dr. Basu and Professor Kuhara. One minor disagreement. Satish Kapoor is no longer the Dean of the Institute of Psychiatry. He is the President of King's College.
Oh,
so this is a huge job.
I stand corrected, sir.
It's amazing actually, because I remember him as a young researcher, and he is just, I don't know what he'll do after becoming president of King's College. There isn't much higher that one can go after that.
Sure.
Anyway,
Sure.
Thank you both for your kind introduction. I, of course, am delighted to talk with you, because I was saying to Dr. Basu, I've known about Bangalore for more than 40 years, and the fact that it is perhaps the number one research institute in India. So I've known a lot about the research there, and also people who have trained at Bangalore, some of whom have come to my department. So I'm going to say I'm actually doing too much, actually, talking about better understanding and better treatment. It's not possible to do justice to both of these, but really just to say that when I started in psychiatry, schizophrenia was a total mystery. People said, we don't understand it, it's an enigma, we don't know the causes. Well, now we do know the causes. We don't know how the causes cause the schizophrenia, but we know what the risk factors are. And we understand better how our treatments work. So if we start, why are we not moving forward? Oh, there we go. So I, of course, should declare that have received payments from various pharmaceutical companies. And essentially, this is for those of you who follow a ladies' fashion, Dolce and Gabbana, D&G. And this is to I think Dr. Basu said that I said there were three important things about the schizophrenia. Actually, there's only two: D&G, dopamine, and genes. And this is not my joke, actually. It's Robin Emsley's, who is a wonderful researcher from South Africa. But one can think of schizophrenia in these terms. And the first thing we know is that striatal dopamine synthesis is elevated in schizophrenia. And if you inject radio-labeled dopa into a person, this will be taken up in the striatum and concentrated there, and you can see it in the red in the top left-hand corner. But you can also see in the figure that people with schizophrenia, when they're acutely psychotic, they synthesize more dopamine than controls. And this has been replicated many times. But what I want to show you now is a study by Samir Johar in our department, who is a Scottish Indian. And he did an amazing study because he managed to persuade manic patients to go into a scanner for 45 minutes and stay still. And that's difficult enough, but he had to persuade the people who ran the scanner to allow the manic patients in because they thought they would break up the machine. But you can see what is very interesting, that when bipolar patients are ill, just like when people with schizophrenia are ill, they show an increase in striatal dopamine. So in that sense, mania and acute schizophrenia are the same. And that's not surprising when you think that both disorders respond to dopamine blockers because, of course, both have an excess of striatal dopamine. So this is the final common pathway to psychosis. And this is I'm sure you've seen versions of this slide before. So this is the PGC, the huge collaboration on psychiatric genetics across all the world, including mostly European patients, but also some Asian patients are included in this. And you can see that now there are 74,000 people with schizophrenia and 101 controls. So, I mean, that's not collected in one center, but collected in lots of centers. And we collect, maybe some of you have participated, we collect samples, we diagnose the patients, we take the DNA, we carry out a genome-wide association study, and we send the results off to Harvard. You don't hear any more for about 2 or 3 years, and then you get your name on a paper in Nature. Fantastic. I've never had my name in papers on Nature before, but I've had several in the last. You have to share them with another 70 or 150 other colleagues, but at least you get your name on a paper in Nature. And initially, when this was first done in 2014, there were 108 places on the genome where patients with schizophrenia differed from controls. But we now know there are, with the expanded data, there are 263 places on the genome where people with schizophrenia differ from controls. And you can see, of course, along the bottom, all the different chromosomes from 1 to 22 in the sex chromosomes. And then you can see the significance, the degree of relationship with schizophrenia. And right in the middle, you can see the biggest peak is on chromosome 6, and that's the HLA-MHC region, which is involved in transplantation. And maybe someone listening will know, but there certainly has been more than one study from India where this was not found in people, in Indian patients. I'm sorry, one study I know where this was not found in patients in India, and I don't know whether that has been replicated or not. But that suggests, at least that in the West, that immunity may be somehow involved in schizophrenia, and it's actually it's suggested that it may be related to synaptic pruning, some of the genes in that area are involved in synaptic pruning, which may be excessive in people with schizophrenia. So when I was young, people argued about whether there was one big gene for schizophrenia or 2 genes. Now we know there are hundreds and hundreds of genes, and they all have a tiny effect. If you inherit the risk allele at one of these sites, maybe your risk of schizophrenia is not 1%, but 1.1 or 1.2%. So they each of them have a very tiny effect. but reassuringly, in this paper, which is about to come out in Nature, there's also been they have taken the top genes, the most important genes, and they have looked to see where they're expressed. And you can, if you look at the right-hand side of the slide, that's the up-to-date data. And up at the top is the frontal cortex. And then these are all brain regions till you get down to the green and and then down to purple. And you can see that the genes are expressed in the brain, which of course is a great relief. You wouldn't expect the genes for schizophrenia to be expressed in the lung or the breast or the small intestine. But sometimes people say that schizophrenia is a disorder of the whole body. Well, at least the genetics is a disorder of the brain, that the genes are expressed in the brain and only to a very limited extent elsewhere. What you can now do, of course, is you can add up all these little risk alleles, and you can weight them according to how important they are, and you get a polygenic risk score, so everybody can get a score. So all of you listening and me and so on, we can all readily get a risk score as to what is our genetic risk of schizophrenia. And if we're at the bottom 10%, compare it with the top 10%, the people at the top 10% are 7 times more likely to develop schizophrenia than the people at the bottom 10%. So we estimate any individual's liability to schizophrenia. And you can apply this to the general population. Now, schizophrenia has traditionally been thought to be a discrete category. You had schizophrenia or you were normal, just like you had measles or you didn't have measles, or you had a broken leg or you didn't have a broken leg. But that was how we thought of it. And we thought people with schizophrenia, they can't think properly, they've got cognitive difficulties, they have poor relations with other people, and they have bizarre ideas, and they can't plan for the future. And then there are normal people who don't have any of these. So they're classically mad people, and here are normal, sane people. Now, the reason I show this is, of course, that it's not because the former president was schizophrenic, but was he entirely normal? I'm not sure. He was certainly, whether Trump got a formal diagnosis or not, he was certainly strange. I'm putting him in the past tense. I hope he's not going to come back again. But this traditional view that there are normal people who are totally normal and there are mad people who are totally mad, I think schizophrenic people are more sensible than we give them credit for most of the time, and normal people are often quite irrational and nonsensical. So now we know there are hundreds of susceptibility genes. This is not compatible with the idea that there's a discrete illness of schizophrenia. It's more compatible with the idea that there's a continuum of liability like this. So we have a normal distribution, and as you go towards the right-hand side, up goes your polygenic risk score. And if you pass a certain threshold, you're more likely to have minor psychotic symptoms in the general population. You're not coming to see a psychiatrist, but you're maybe a bit paranoid about your neighbor. You think he's trying to bang on your flat wall to keep you awake, or you think that the man down the street is somehow trying to influence your mind. And such ideas are common in the general population. If your risk is a bit higher, then you might be referred to a prodrome clinic. It's what they call the at-risk mental state that Pat McGorry popularized, that somebody who has some transient symptoms which are suggestive of psychosis, but it's not frank psychosis. If your rates are if your scores are a bit higher, you might have psychotic disorder, but you wouldn't qualify for a diagnosis of schizophrenia. And then if your risk is very high, you're more likely to get a diagnosis of schizophrenia. So schizophrenia is part of a distribution. And for much of my early life, there were long arguments about, was the RDC definition of schizophrenia better than the DSM schizophrenia definition? Was it better than the ICD definition? And really, these are just a question of where on this continuum you put your cutoff. It's like hypertension or obesity. Where does it start? It's part of a continuum, or anemia. Many medical disorders are on a continuum. The other thing we've learned is that the genetics of schizophrenia is not totally different from the genetics of other conditions. And along the bottom here, you'll see the correlation between the genes for schizophrenia with other conditions. And you will see up at the very top, I've ringed it in red, the correlation between genes for schizophrenia and genes for bipolar disorder is about 0.66. It's about 2/3. So there is a huge overlap, 2/3 overlap in the genes for schizophrenia and the genes for bipolar disorder. And you can see to a lesser extent, there is overlap with depression, with OCD, with anxiety, and even with ADHD. So there is a negative relationship with intelligence. So what does this mean? Well, one of the things is that the reason we have such difficulty distinguish between schizophrenia and bipolar disorder is because they share the same genetic predisposition, or 2/3 of the genes are the same, and they share the same propensity to synthesize excessive dopamine. So this is why they quite often look alike. And I'm sure you're all familiar with the patient who has been admitted to hospital 7 or 8 times, and 3 times has had a diagnosis of schizophrenia, and a couple of times a diagnosis of bipolar disorder with psychotic symptoms, and other times a diagnosis of schizoaffective disorder. We sometimes think this is ridiculous, but it's because they are on a continuum. And it's not because we are stupid psychiatrists, we can't make the distinction. It's because they overlap to such a great extent. So there's genetic and neurochemical overlap. Oh, excuse me, let me if I go back. But the important way in which bipolar disorder and schizophrenia differ is in development. And for many years, I've been interested in obstetric complications. And we know that people with obstetric complications, they're premature, or they have abnormal growth and development, or they have a complicated delivery with lots of asphyxia and lacking in oxygen. We know that this increases the risk of schizophrenia. And we did a meta-analysis way back. Well, when I say we, when students will be aware of this, when professors say we did this, they mean somebody else did it. And they mean some PhD student or some junior person. And in this case, it was Mary Cannon, actually who did the work. And recently, that was, that was back in 2002. Recently, my colleagues and I have done an updated version which came out in Lancet Psychiatry last year. And again, looking at the pre and perinatal risk factors for psychosis. And it confirmed nearly all the findings that Mary Cannon had outlined many years ago. But again, it's the effects are relatively small, like a doubling of the risk or a trebling of the risk. So if you're born with a very long labor and hypoxic, your risk may be 6 times greater than but that still means only 6% of people who are hypoxic at birth will develop schizophrenia. Over 90% won't. So obstetric complications were one of the first environmental risk factors that we found related to schizophrenia. I talked about the genes for schizophrenia, the polygenes, the little genes, and these are by far the most important. But about 3 or 4% of, no, excuse me, 3% of people with schizophrenia have a copy number variant. And I've just illustrated this here. So this is where quite a big chunk of the chromosome is deleted. So you lose a section here, or else you get a duplication here. So this is why they're called copy number variants, because the number of repeats varies. This was found in autism. Maybe 10-15% at least of people with autism have a copy number variant. And these copy number variants are also found in learning disability and epilepsy. And now we know that they're also found in excess in schizophrenia. So about 3% of people with schizophrenia have a copy number variant. And Mike Owen, he pointed out that this suggests that there's a developmental continuum. Oh, I didn't say it's the same copy number variants that cause autism and learning disability that cause schizophrenia. And somehow or other, if you have a high, if somehow the effect is very large and early, then you may get, say, learning disability or autism. But if you have the same copy number variant, but somehow or other, it's not, it doesn't have such a great effect, then you may develop schizophrenia. So we know that if you look at, excuse me, this slide hasn't quite come out. This is from a cohort in New Zealand, and this is supposedly, and I apologize for this slide, this is along this midline here would be the normal population, and this is children who later go up to develop schizophrenia. And this is poorer motor development, and this is poorer receptive language, and this is IQ. So children who develop, children who are going to develop schizophrenia, on average, their IQ is lower. What is the average IQ of an Englishman? I don't mind because I'm Scottish. You can say anything terrible. No, it's 100. Of course, the IQ of average IQ of Scottish people, of Indian people, of English people, New Zealanders is 100. But of those children who go on to develop schizophrenia, it's 95. It's not to say there are not clever people who develop schizophrenia, but they're not so common. But interestingly, for mania, it's the opposite. That so children who are going to develop mania tend to have good motor development, and there's even a slight increase in some samples in their intelligence. So this is the main area in which people with schizophrenia and mania differ. It's their cognitive development. So you know that drug use can also increase the risk of schizophrenia. And I'm not very familiar with the Indian situation. In the UK, amphetamine psychosis has a modest effect. It has a big effect if you come across it, but we don't see many people with amphetamine psychosis or even methamphetamine. But you will know that in the Far East, in Japan and Taiwan, and in Australia and South Africa, methamphetamine psychosis is a very big problem. I'd be interested to know whether you see this in India or not. In the UK, a much bigger problem is cannabis. And interestingly, the first serious look at whether cannabis can cause psychosis was Indian. It was the Commission on Indian Hemp, which reported in 1893 and 1894. And this was a very big endeavor. So the British Raj, of course, it was colonial India at the time. They had set up mental hospitals, asylums around some of the big cities, and they were a bit dismayed to find that they were filling up with people who had been using cannabis. and they decided to have an investigation into this. So this investigation committee consisted of 8 people. And I think there were 4 Indian people and 4 British people on this commission, but the chairman was British and had a casting vote. So of course the British Raj wanted to control this. But interestingly, the doctors were Indian. There were Indian doctors from the asylums, and the British people tended to be people from the tax department and bureaucrats. And this is just one of the quotes. There are 10 volumes to this document, but you don't need to read them all. You can read this nice summary by Dr. Deji Ayurindi, which is in psychological medicine. And here's one bit which said, the majority of habitual consumers become permanently insane, never to be cured. Some become temporarily so, and some become sane when they break off the habit. But the symptoms are apt to be reintroduced on resuming the habit. And of course, we know that this is the case. But there was so cannabis was legal in India at the time, but the Indian doctors who were working in the asylums were very worried about this. They said, we need to make cannabis illegal because it's causing such havoc. And the British representatives didn't much care about people going mad. They cared about the tax revenue. So they said, if we make cannabis illegal, where will we get all this tax from? So they eventually overruled the Indian doctors, and therefore cannabis stayed legal. Now, this is interesting because this is the same argument that's happening all over America. Doctors are saying that cannabis can induce psychosis, and the governors of states are saying, well, maybe so, but think of all the tax revenue we can get if we allow people to smoke cannabis. So the more things change, the more they stay the same in some ways. So cannabis use disorders, it's now incontrovertible that heavy cannabis use is associated with psychosis. There are 3 meta-analyses, and they show that cannabis use is a risk factor for psychotic disorder. This is a study that we actually did, or here you can see the senior author. This is Vangelis Vassos, who is in our department, and he did a meta-analysis with a lady called Marconi, and each of these lines is a study, and along the bottom axis is exposure to cannabis. The left-hand side shows the 20% who had least cannabis, never used cannabis or very rarely, and the top and the extreme right shows those who had the most cannabis. And each study shows the odds ratio of going psychotic. And you can see this bottom study. This is from the US in 1990. It showed only a small effect, but cannabis was quite weak in 1990 in the US. It was traditional cannabis, rather weak. And here on the other side, you can see cannabis being very strong. By 2012, cannabis has become a very, very strong, and the odds ratio is very much higher. It's very appropriate, I think, that Vangelis said the odds ratio, the pooled odds ratio. So the gentleman in the pool here is calculated the pooled odds ratio as 3.9. You can probably hear my dog barking. That means there is somebody at my door and there's nobody here. So I have to quickly go and answer it. I'll just run and come back to you. So you can look at this nice picture for
So Swapnajit, this was not my dog barking. I know that you muted me, and I was going to WhatsApp you saying that it's not my dog, but Sir Robin's dog, which is barking.
Yes, sir. Yes, sir. Sorry, sir.
We can have a good laugh over that because I'm sitting in my office here. I know Noel would be barking just like his dog is barking when a guest is there, but I'm in my office. I think this is going. Yeah, I think it's back. Okay.
Here I am back again. So this is a new thing for you. You've never had anybody giving a lecture who had to go and stop his dog barking and answer the door. But you can see this, that the odds ratio increases the more cannabis that you've been using. So other environmental factors that increase the risk of psychosis. This is from the ESOP study, which is an epidemiological study that we did across 3 centers in the UK. Oops, why are we not going? Moving on. There we are. So childhood physical and sexual abuse and neglect. I was very slow to realize this. And our psychologists have said this for a very long time. But our ESOP study was the first, which was 2004, was the first study we did to show that that childhood abuse increases the risk of psychosis. It's not very surprising because it increases the risk of all psychiatric disorders, and is surprisingly common, at least in the UK. We know that migration is a risk factor, that migrants coming into the UK are people from an ethnic minority have a greatly increased risk, particularly migrants of African origin. And curiously, migrants of Indian origin. So the migrants into the UK of African origin are about 6 times more likely to get a diagnosis of schizophrenia. White migrants from Europe or North America are about 2.5 times more likely to get a diagnosis of schizophrenia than the British natives. And Indian migrants are 1.5 times. So it's interesting that Indian migrants are less likely to get psychosis than white migrants. And it's been a great puzzle to us as to why this is. Maybe it's to do with the support of the extended Indian families, that if you're a migrant by yourself in a foreign country, you're much more stressed than if your extended family is with you. We don't know, whether that's speculation. We don't know if that's true. We know that bullying is a risk factor. And here is slightly complicated because we know that children who get bullied are more likely to have problems. So it may be that you start off with some problems which set you out from your other children at your school, and that sets you up, makes you more likely to be bullied. So you may have a genetic predisposition, and this may be then compounded by the bullying. Being brought up in the inner city seems to increase risk, at least in Northern Europe. I don't know any studies from India about this, but it doesn't operate in Southern Europe. So people we've done a big study called Dr. Basu mentioned it, the EUGI study across Europe. The incidence of psychosis was much higher in Amsterdam, London, and Paris, than in country areas. But in Madrid and Palermo and cities in Spain and in Italy, there wasn't the same difference that between the countryside and the inner city. So it's one of these things that's in textbooks because it's been studied in Northern Europe, but we don't know whether it applies elsewhere in the world. And we know that adversity, if you lose your job, or your wife leaves you, or your son is killed in a road accident, you're more likely to get depressed. Intrusive life events are more likely to provoke schizophrenia. Being burgled, being beaten up, being somehow your sense of self being violated is more likely to be associated with psychosis. But I'd spent a lot of time talking about dopamine dysregulation. Can social factors cause this? This is a very nice study from Montreal. And this is a study where they took 3 groups of people. One were normal subjects, one were people in the high risk prodromal people who might be about to develop psychosis, and one group were people with schizophrenia. And they gave them the Montreal stress test. And this is a test where you're asked to do arithmetic when you're in the scanner. and they make the arithmetic just too difficult for you. So you try and do as the best you can, and yet you know you're not doing well. Then sometimes they tell you that you're wrong when you're right. So the question might be, what is 7 times 3? And you answer 21, and they say wrong. And then they're on to the next one, and you think, was that wrong? Was that right? And then a voice says, you're the worst in your group. Everybody else is doing better than you. Are you not trying hard? Remember that we're going to put the results up on the wall, so everybody will know how well you've done. So this is very stressful. So in normal individuals on the left, you can just see a little bit of blue suggesting some dopamine release. Here are the people in the prodrome. You can see a lot of green and blue suggesting that they're synthesizing and releasing more dopamine. And here you can see people with schizophrenia. You can see that they're synthesizing and releasing the most dopamine. So this shows you how sensitive people with schizophrenia are to stress. And what do we do with people with schizophrenia? At least in England, if they have nowhere to live, we send them to the worst part of town to live in horrible hostels with drug dealers and in poverty and in places that most of us would not cope with. And yet they are especially sensitive to stress. So the final common pathway to psychosis is dopamine dysregulation. Social factors can cause this: stress, childhood, adversity, migration, drug abuse, all are known to impact on striatal dopamine. So what do? We try and block the effects of the increased synthesis of dopamine. So to remind you, the abnormality in schizophrenia is mainly presynaptic. There is too much dopamine synthesized and released, and it goes across and it hits the D2 receptor. And what we try and do, you get the psychosis. And what we try and do is to block these receptors with the antipsychotic. And that mostly works in 85, 90% of people at first episode. So we have people with psychosis, they have a sensitized dopamine system. If they are abusing drugs or they have acute stress, this causes them to release excessive dopamine. This causes aberrant processing of stimuli. This is the contribution of Satish Kapoor, that he said that the dopamine is released and it causes you to everything around you to seem more important and more significant and more intense. And you begin to wonder, why am I experiencing all these strange perceptual abnormalities? If you have been abused as a child, or if you've been discriminated against as a migrant, then you tend to have a biased cognitive schema so that you think that other people are against you. When that happens, when you're having strange experiences, you interpret them in a paranoid way, you develop psychosis. Once you develop psychosis, this is extraordinarily stressful because you think that your parents are trying to poison you, or you think that your neighbors are ganging up to kill you. So this causes the release of more dopamine, and this causes more paranoia, which makes you even more convinced you're going to be killed. So then I don't know what happens in Bangalore, but in London, then the neighbors call the police and they say that this man is shouting at us and he's waving a knife at us. Please come and take him to hospital. So the police come and a psychiatrist comes. The psychiatrist goes and says, Mr. Brown, I'm sorry, you don't seem to be well. You need to come into my nice hospital. That Maudsley Hospital, I'm not going near. You can see the Maudsley Hospital behind me. But he says, I've been there before. That's a terrible place. But the doctor says, oh, I think you really ought to come in. And he says, no. So he said, well, the doctor says, well, I'll have to ask my friends, the police, to help you. So by this time, he's even more stressed and he gets into hospital and the nurses approach him with a big needle and he's sure he's going to be poisoned. And so he releases more dopamine. So you can see how this continues and people can get worse and worse. I mean, this is not to say that so what we're doing is we're trying to reduce the stress We're trying to do CBT for the biased cognitive schema, and there are various new treatments as well we can try. We can try CBT, and of course, this is very important CBT. This is just our routine CBT in our unit, and you can see that the people who the blue is voices. Whoops, excuse me. The blue is voices. The red are delusions, and you can see that delusions especially respond to CBT. Voices to a lesser extent. The outcome is much better. Schizophrenia is not a progressive disorder in the main. Not mainly. We've followed up people for 10 years, and at 10 years, 40% of those with a diagnosis of schizophrenia had had no psychotic symptoms for 2 years. That's not to say that they were architects and entrepreneurs. Some of them had many problems, but they weren't frankly psychotic. 19% of them had no psychotic symptoms and were not taking antipsychotics. So 20% were taking antipsychotics, 20% weren't, and had no psychotic symptoms. And there have been 3 other studies which have come to similar conclusions. Excuse me. So it does seem that about 20% of people with schizophrenia can eventually come off their antipsychotics. The final thing I wanted just to say a little bit about is the question of why do antipsychotics stop working? And this is data from way back 40 years ago from a man called Charles Marsden, who gave antipsychotics to rats. And he said long-term antipsychotic treatment causes the proliferation of dopamine receptor sites, accompanied by an exaggerated response to dopamine agonists, that's amphetamine, and a decreased response to antipsychotics. The dopamine receptor population becomes supersensitive. And this has been confirmed many other times. And here is what I've called dopamine royalty. Phil Seaman, who was really a very important researcher in dopamine. And here with the funny hat is Satish Kapoor. They gave haloperidol or olanzapine to rats, and they showed that when they gave them amphetamine, the antipsychotics blocked the effect of amphetamine. But as the weeks went by, this blockage got weaker. And after about 6 or 7 weeks, they found the antipsychotics didn't block the effect of the amphetamine, but you could increase the dose of the antipsychotics, and again, it blocked the effect of the amphetamine for a few weeks, then it stopped again. So this, they said, this may cause a breakthrough relapse during ongoing antipsychotic treatment. So just to illustrate it, the top here is the normal presynaptic release of dopamine hitting the receptor, normal dopamine activity. Here is somebody who's had lots of antipsychotics. What happens at the D2 receptors have the effect of antipsychotics blocked, and therefore they upregulate, they proliferate, because they're looking to try and grab whatever dopamine there is. And this is okay while they're receiving antipsychotics, but if they stop, well, it may be okay, or it may be that the effect of antipsychotics wears off. But especially if you stop the antipsychotics, you get increased dopamine activity. So a major problem is the frequency of relapse when antipsychotics are reduced or stopped. So how should we reduce the dose of antipsychotics? Well, this is the dopamine supersensitivity psychosis first proposed 40 years ago. And Joanna Moncrief pointed out that sometimes people relapse when they've stopped antipsychotics, not because of their underlying illness, but because of the withdrawal of the antipsychotics, because the withdrawal of the antipsychotics when the person is in a condition of supersensitivity. So I just wanted to finish with pointing this out, that if you're trying to reduce the dose of haloperidol, The traditional way is to start off with something, well, this is a small dose. This is 4 milligrams of haloperidol. That causes 80% blockage of the D2 occupancy. If you reduce it to 3 milligrams, that causes about 76% occupancy of the D2 receptor. So you may get less sedation and less effect on appetite, but it doesn't change the blockade much. If you go down to 2 milligrams, then the receptor blockade is down to about 65%. Once you start going to 1 milligram, it falls to under 60%, but still there's a high degree of blockade there. It's between 1 milligram and 0 milligrams that you have a plummeting of the occupancy of the blockade of the receptor. So people are especially likely to relapse when you're going from 1 milligram of haloperidol or equivalent to 0, and you have to be very, very careful and go from maybe 1 milligram to 0.75, 0.5, 0.25, and using a liquid rather than tablets. So I guess here's another example of this. What you could do is to come down to just over 1 milligram when you've got 60% occupancy, and then you decrease much more slowly, and you have to do that very, very slowly over weeks and months. There's lots of studies where you take people on olanzapine or haloperidol and you randomize them to continuing or going to a placebo. And usually these studies are done by switching the people quite abruptly. And they relapse. The people on placebo relapse. If you switch them, if you decrease the antipsychotic much more slowly, or particularly if it has been a long-acting antipsychotic, then the relapse rate is very much less. So the point I'm making is it's important to try and decrease antipsychotics very, very slowly. So let me conclude. Schizophrenia, it's no longer a mystery. We have a clear understanding of the risk factors. Now we know these, we should be thinking about public health. How can we avoid these risk factors? Can we decrease child abuse? Can we be nicer to migrants? Can we avoid drug abuse? Schizophrenia is not a discrete entity. It merges into bipolar disorder, but the schizophrenia is associated with cognitive impairment. Minor degrees of psychosis are distributed throughout the population. Schizophrenia is just what we call the extreme end of the spectrum. The risk factors ultimately converge on dopamine dysfunction. We can block this in most cases, but in some cases, the dopamine supersensitivity develops and can cause relapse, or even in some cases cause treatment resistance. So I will stop at that point and thank you all very much for listening.
Thank you so much, Professor Murray. It was an absolutely fascinating talk, but I'll let Dr. Kulhara to please take over. And sir, if you note, then Dr. Sudhir Khandelwal and a few of other alumni are also there if they'd like to make any comments. Dr. Kulhara, please. Till such time that Dr. Kulhara is trying to unmute himself, may I just to get the ball rolling?
Okay, I have unmuted
yeah. Oh,
myself.
Fine. You've got your voice, sir.
Yeah. I was just saying that it's the brilliance of Sir Robin that he has been, in a simplified way, able to tell us the relationship between the genetics, between the treatment, and then the cycle as it goes. And all these things are very important, and all these things are very important now. And the most important thing to understand now is that it's no longer an enigmatic or a mysterious disorder as it is thought to be, though it shares quite a lot of genetic and other things common with bipolar disorders. But the treatment aspect about remain the same, and the importance of antipsychotics and managing drug regimes is very, very important, as pointed out by Sir Robin. I'll not take much time because there are quite a lot of people who wish to comment, ask questions. Particularly, I'll strongly appeal to the younger colleagues to come forward and ask questions. Thank you very much, Debashish. Thank you very much, Sir Robin, for giving me this opportunity to chair your session.
One thing I could add, the beginnings of the relationship between the genes and the dopamine are beginning to come out. Many of you will know about the deletion on chromosome 21, which causes the paleo-cardiofacial syndrome. And in this, about 20% of people develop psychosis. And one of my colleagues has now taken these people before they are psychotic. They just have the deletion on chromosome 21 and shown that these people have a much higher dopamine synthesis level. So they have a very clear genetic abnormality, which causes a very clear dopamine abnormality. Sorry, more questions, please.
Debashish, please take over.
Yeah. Well, Dr. Kamala has just complimented by saying it's an excellent presentation by Professor Murray. Thanks to my teachers for giving us this opportunity to listen to such a legend. Thank you. Kamala is one of our students who is in who heads the Department of Psychiatry in Assam now. So thank you, Kamala. Prashant has written a kind of interesting comment, which probably you can also see also, Professor Murray. He says that, in summary, does providing a healthy childhood and adequate coping skills to anyone actually acts as a protective factor towards developing schizophrenia, despite having genetic risk factors?
Fantastic question. Fantastic question. So I always wonder about this. Say you take somebody who has a high predisposition to schizophrenia, or maybe he's a twin and his co-twin develops schizophrenia, but he is lucky and he's in a class at school where he's not very good cognitively, but his teacher is wonderfully supportive and encourages him. And then he still keeps hard at his studies. And maybe when he becomes 14, he meets into his class comes a beautiful blonde lady, or a brunette, a girl rather, who for some reason likes him very much and becomes his girlfriend and stays with him. And he may be socially inadequate and hopeless with other people, but she's an extrovert and sociable. And can she protect him from developing psychosis? This is what I think our National Health Service should be doing. We take people with schizotypal personality, lots of disadvantages, and they give them very pretty, sociable girlfriends. Sadly, we can't do that. But I wonder. I tell you another pair of twins we have. We had a pair of twins where they both had very difficult births, and one developed a hemiplegia at birth, and he was cognitively not very able, and he went through childhood and never got any exam results and became a gardener. And his identical co-twin didn't develop a hemiplegia, although having difficulties at birth. He was very bright at school and he went to Oxford, and in his second year he developed psychosis. So isn't that funny that the one who had the neurodevelopmental insult had a motor abnormality, the one who didn't show the gross developmental insult became psychotic? So it could be that in one, the hypoxia hit the motor area, but spared maybe the hippocampus or the circuits involved in schizophrenia, and the other one who he unfortunately, though his motor area was spared, so one it hit the motor area, the other one it hit the circuits involved in schizophrenia. So it is a very interesting question.
Thank you. Thank you very much. We have now questions coming up. I hope you will be able to cope with them, but please do say when the time is up.
Yes. So does the withdrawal of antipsychotics lead to a downregulation in the number of receptors? Yes, it does. We don't know how, and I should say people differ. I'm not saying that everybody develops a high degree of dopamine supersensitivity, but to be cautious, I think if you're decreasing the antipsychotics, I think you should decrease only by the amount which would cause a 10% reduction in D2 occupancy. And if you do that and then wait several weeks and see how the patient is, and then if they're getting on fine, say we decrease by another 10%. So it may be the patient's been on antipsychotics for 2 or 3 years. You might take 3 or 4 months to decrease the antipsychotics. If they've been on antipsychotics for 5 or 10 years, you might take a year. But what often happens in Britain, and I don't know if this happens in Bangalore, people have their first episode and they recover from their first episode and they come back to the outpatient clinic and they say, I would like to stop my antipsychotic now. And the psychiatrist says, no, you can't stop your antipsychotics. You have to stay on these forever. And of course, this really annoys the patient. So they never come back. And 2 weeks later, they stop their antipsychotics and relapse. So I think it's better to negotiate with patients. If you say to patients, you can never stop your antipsychotic, some of them will just refuse. Other ones you can say, well, why don't we try just a little bit and decrease and see how you get on? But if things get worse, you have to go back to the higher dose. So it's better to negotiate with the patients.
Wonderful. We have questions coming up like a flood, Professor Murray. And there's one by Himani, clinical staging models. Another one by Raja Ghosh, who happens to be, I think, Dr. Kulhara's batchmate from the 1970s days in PGI and now settled in UK. So that's a very provocative question. Do you believe that schizophrenia as a disease concept is still valid? But before that, Himani's question about the staging, clinical staging, people are talking about the different stages.
Yes, I am a bit skeptical about that. I don't believe schizophrenia is progressive. And so I don't think there is decreased cortical volume as part of schizophrenia. I don't think, well, we know that the polygenic risk score for schizophrenia does not induce progressive decline in cognition. It causes a decline in childhood, but from adolescence onwards, and certainly from the onset of schizophrenia, there is no decline in cognition. Sometimes it appears there is because anticholinergics or drug abuse or too much antipsychotics can impair cognition. So I think the worst thing you can say to patients is that you have a progressive a disease called schizophrenia, that this is so depressing for patients. You should always hold out hope. And surprisingly, patients can recover. As patients get older, dopamine levels go down. I mean, think of me. I'm not going to get schizophrenia. What dopamine disorder might I get? Parkinson's, because as you get older, your dopamine activity goes down, which is good for psychosis. Why does psychosis occur in adolescence and 20s? Because your dopamine systems are at peak performance then. So I'm skeptical. I don't think there are these, there is such a program. First of all, I don't believe in the clinical high risk approach. I think it's people who come to prodromal clinics are specially selected. If we try and prevent schizophrenia, we should prevent it at the baseline by preventing people being exposed to risk factors. Just waiting till people develop the prodrome is like waiting till people develop angina and then trying to stop them developing a coronary artery disease. It's too late. Next question. Oh, do I still believe it's a disease concept? No. I don't say to people that you have a disease. I say you have a excuse me. I don't. In clinical practice, I don't use the term schizophrenia because I think it's in Britain. It's too depressing. The newspapers have convinced everybody that schizophrenia is a madman with a hatchet, with an axe. So I say you have a predisposition to what we call psychotic symptoms, and you have to be very careful because it may come back again. But I don't say I don't say you're. Sometimes psychiatrists say you'll never be able to go back to university. You'll not be able to study. Of course they won't if they're told this. But some people can make a surprising recovery sometimes. What was the next one?
From Shalini's longish message, but I think it's worthwhile if you have the time, sir.
So people moving from, it's disappeared.
Migration. This is about the impact of migration on prevalence of schizophrenia. To add, she writes, in our country, the recent National Mental Health Survey showed people migrating from rural parts. So we're talking about internal migration, which is a very important thing in India particularly, showed people migrating from rural parts to metro cities. Migration within the same country had nearly threefold greater prevalence of psychotic disorders than the rural and urban counterparts.
That's fascinating.
Yes.
Can you send me that reference? I'd love to have that reference.
Yes.
I think the equivalent study I know is from Italy, and in Bologna, which is a wealthy area in the north of Italy, they have a lot of migrants from the south, from places like Sicily, and they treat them very badly. The northern Italians regard the people from the south, they call them Africans, and they are often discriminate against them, and they have an increased risk. But it's very interesting. Where did schizophrenia come from? Why were all the mental hospitals built in the 1800s? Why weren't they building mental hospitals in the 1500s and earlier, when the society was mainly rural? It was when society became urban that and people migrated to the city that we had all these people going psychotic. So I think this evidence I've just heard is very fascinating.
Yeah, thank you. And Shalini has already messaged me the PDF. I will definitely, I'll send it over to you by email.
Very
these
good.
things are fast. I think we are running out of, I mean, I'm not running out of time, but probably you are, but then we still have a couple of last very interesting.
No, I'm at home today, so this is the most exciting thing I'm doing today.
Because I think people are just very excited to have you with us, that they would like to let go. So Dr. Ghosh writes that, so by the way, Dr. Raja Ghosh or Anindya Ghosh, if you're still there, would you like to make an appearance, kind of a video appearance, and say hi? Dr. Raja Ghosh is one of our very senior alumni who moved to England, I don't know, decades ago. And then he was very, there you are.
There we are.
And yes, and where are you, Dr. Ghosh, these days? Are you in southern part of England?
No. I'm in West Wales, in Pembrokeshire.
Oh, yes. Hello, Doctor.
Hello, Robin would know where I am.
Nice to see you.
Yeah. And so because he was particularly interested, he emailed me, say that I would definitely attend this talk. And does he still believe in schizophrenia? Because I was going through your mistakes I've made paper, and you ended in the last paragraph. You write that I expect, well, before that, you say that I'm getting older, and now people are asking me for the future of schizophrenia. That's like asking, I find myself, that's like asking Mick Jagger to comment on the likely new trends in hip hop. So that was a fascinating sentence. And then we finish by saying that I expect to see the end of the concept of schizophrenia soon. So I don't know whether you'd like to elaborate further on that.
So I would, yeah. Before we hear Dr. Ghosh, I would say that I think this syndrome is, I prefer to think about psychosis and the individual causes of psychosis. And we talked about copy number variants, and we talked about cannabis, and we talked about child abuse, and then there are people with a high genetic loading and low genetic loading. I think we'll be able to tease apart the different etaological types. Whether I think we have to treat them different. I mean, you can't treat the person who has been normal and sociable till they started abusing amphetamine the same as the person who has been abused as a child. So we have to have different treatments. Dr. Ghosh, your question.
Yeah, this is the other Ghosh, a younger Ghosh, who is our faculty colleague and one of our alumni as well. He writes that, needless to say, an excellent one. When you say schizophrenia is in continuum, I think we are all talking about the similar theme with quote unquote normal population. What continuum are you suggesting? Thinking, cognition, perception, or of risk factors? So continuum of what, continuum of genetic load or of dopamine?
Yeah. So we know that there is a continuum of genetic loading. We certainly know that. But in terms of the phenotype, it's still controversial. Is it so you can measure minor psychotic symptoms in the general population, and you can measure the people can fill in something like the CAPE, which assesses minor psychotic symptoms. So that's like a subclinical psychosis. But then, of course, you can measure a schizotypy with things like the CIS-R. And we have done, I mentioned several times, this big EUGI study, where we looked at psychosis across 16 sites in Europe. And we looked at the incidence, but we also rated the general population according to for their schizotypy and according to their CAPE, the minor psychotic symptoms. And I thought that it would be minor psychotic symptoms that would correlate with the incidence, but it wasn't. It was the measure on the schizotypy, which surprised me. But that's the great thing about research. You're always surprised, unless you're very good at prediction. So I think this is something that we're just beginning to understand. Is it a single continuum? For schizophrenia, there's clearly a neurodevelopmental continuum. That there are those people who are who have a more or less extent of cognitive impairment. And that is not shared with bipolar disorder. So you can think that people with schizophrenia are at the confluence of two different continua. One, this developmental impairment, which is really shared with IQ, and two, this liability to severe mental illness, which is shared with bipolar disorder. Bipolar disorder just has the liability to severe mental illness, but it doesn't have the additional neurodevelopmental impairment. So I would think there are at least two continua, but given that all the genes that converge in schizophrenia, it may well be that there are others.
Well, that's a very, very thought-provoking response, Professor Marey. You have kind of set us all thinking and wondering. It's just that there's a last question, or rather a kind of an interesting comment from one of our students here. And he says that we talked about continuum of normal to abnormal. Shall we treat negative symptoms? I believe it's important to make them independent so that they won't be burdened to so-called sane people who are also deluded to a certain degree and believe doing good to underprivileged people with schizophrenia. What should be our goal while treating them? I'm not sure I've understood the question very well.
Yeah, so I agree that one of the slightly anxiety-provoking things about a continuum is what will drug companies do to it. drug companies would like to give more and more people in the population antipsychotics. And we have to have limits. If you think of hypertension as the model, in Britain, the diastolic blood pressure of 90 is the cutoff for hypertension. Is it the same in India?
Yep.
In the USA, it's now 85. So they have changed their definition of hypertension in order to intervene at a less extreme point of view. And so I think we have to be wary that where we have to be cautious. We as psychiatrists have quite enough work to do without treating the increasingly worried well. In Britain, it's only private practitioners in Harley Street that spend their time looking after normal people. But I think we need to concentrate on the seriously ill. The issue of negative symptoms are so difficult to assess. And to assess them in the normal population, think of your friends. Who's got negative symptoms and who's not got negative symptoms? Or indeed, who has disorganization of thought? And you can tell if one of your friends is paranoid, but telling if they have negative symptoms, a little bit of negative symptoms is difficult to know.
Wonderful. I think there's a last one, and we'll have to finish after this. I'm afraid, but Anisha, who is now training in the UK, one of our students from our institute, she writes that what characteristics of people with FEP, first episode psychosis, end up developing treatment resistance. So we're talking about long process there. Also, I've been seeing a number of cases with ASD, autism spectrum disorder, presenting with psychosis. Can they be a single entity or two different entities? As sometimes clinicians feel that this paranoid thinking appears more secondary to ASD.
Well, I mean, ASD is not, I mean, severe ASD is not so common, but certainly you do see people with autism who develop psychosis. And as I mentioned, people with copy number variants, they can present with autism in childhood, and then they may get, it may be compounded. So I think the copy number variants are a cause of the overlap. And I think that is likely to be a bit different from a psycho. So I think somebody having autism in childhood and progressing to psychosis is different from somebody who is entirely well till they're 32 and they start abusing drugs, or they are in a horrendous social situation which precipitates a psychosis. So I think that's different. The question about what are the characteristics of people with first episode psychosis who end up with treatment resistance? I simplified things. I think there are two kinds of treatment resistance. One is the type where people develop treatment resistance consequent upon too high doses of antipsychotics. And these people just look the same as everybody else at first onset psychosis. There's nothing to distinguish these people with. But there is a type of people who never respond to antipsychotics. So about 10% of people, at least in the UK, who have first episode psychosis, given antipsychotics, they don't respond. And we keep fiddling about with them, giving them different antipsychotics and so on. And after a few years, we decide they have treatment resistance. Now, these people are very clearly different. They have lower IQ, they have more cognitive abnormalities, they may have a copy number variant, they're more likely to have structural brain abnormalities, they're more likely to be male, they're more likely to have had premorbid difficulties, they're more likely to have minor physical anomalies. So they're like a more neurodevelopmentally impaired group, which have always done worse and will do worse following their onset as well.
Well, I don't know how to thank you, really. There's a very last one, and this is,
yes,
I promise this is the last
that.
question. Yes, please. Yeah. What is the
I don't know
future of
how old-
schizophrenia?
I don't know how old Dr. Rana is, but I am 76. Would you ask a 76-year-old the future of physics or astronomy or mathematics or chemistry? It's ridiculous. You should be telling me what the future of schizophrenia will be like.
Okay, I think with that, I mean, I wish we could go on forever, really. I think we're thoroughly enjoying ourselves, honestly, and this is going to be a memorable one, but I'll let Dr. Kulhara please say the kind of the summing up, winding up words, and then Dr. Swapnajit for that last bit of certificate thing. Yes.
Well, I really wish to thank Sir Robin for a most erudite, at the same time, very, very informal approach to presenting complicated ideas. The ease with which he has been able to project and talk about complicated things just surprises me. And I really admire that ability to put complex things in simple ways. Not that by putting things in simple ways make things less complex, they still remain complex, but at least your understanding grows and you do look at the complexities in a different way. Secondly, schizophrenia, or whatever term one wants to use, psychosis, psychotic disorders, or psychosis group of disorders, it will always remain a challenge. It will always remain a challenge, and it's futile to ask people like me and Sir Robin what the future would be, what the future treatment would be, etc., because we won't be there to say whether that is going to be true or not. But Sir Robin, you have made my evening most memorable and enjoyable. It's my misfortune that I never met you personally, but maybe, God willing, someday I'll meet you personally. Thank you very much, sir.
Look forward
Thank
to
So just in the end, before we let you go, of course, we can't pay you, and because you are unpayable, but all we can say is that there's something which we are going to remember all through our life, probably, and the students will remember when they grow up that they did watch a talk by Professor Sir Robin Murray. Some of them will not be able to appreciate the depth of the take, as Dr. Kulhara said, complex, said, made in a very casual, almost joking, humorous way. But I'm sure they would appreciate this later on once they read more of your studies and connect with that. So all we can give in this virtual world, Sir Robin, is a virtual certificate of our heartfelt appreciation from the core and the bottom of our hearts. That's all we can say. We'll mail to you. I know it doesn't mean anything to you, but it's just our small way of showing that we respect you and we loved it.
Thank you very much, Dr. Basu. But you can do one thing. You can invite me when COVID is over to come. I'm not asking for a lot of travel expenses or things like that, but I would like to come and see Bangalore at some.
We are in Chandigarh. I think we are in the northern part of India, not in Bangalore. Bangalore is in the southern part of India. So we are in Chandigarh. Wow.
Yeah. My apologies. How did I get this wrong?
That's fine, because this is the city which was the first design city by design, which was made by the French architect Le Corbusier, and after independence of India in the 1950s. And so this is a beautiful, nice city. Your invitation is always
all these years I've been thinking that Professor Wigg started the wrong place. But Chandigarh is where the IPSS did the studies back in the 1980s.
DOSMED.
DOSMED was there. Yeah. So
not IPSS.
So
PGI has a, yes.
I know these did it. So my apologies for that.
No. It's just fine. Yeah. So thank you very much. And I think we will end the session here today. We can't thank you enough, but yes, and our invitation will always stand whenever we can make it. It'll be our pleasure and pride to have you with us someday, God willing. But